For those of you who have just joined us, welcome to the Biologics webinar, Ask an Integrative Medicine Expert. People living with inflammatory bowel disease, or IBD, are among the most frequent users of complementary and alternative medicine in North America. Today's presenters are both naturopaths, and they'll chat about their strategies for gut health and treating IBD, as well as how those can be integrated with more standard or conventional approaches. We'll also touch on how this holistic view aligns with QB-ECHO SSI being studied in Restore Crohn's disease clinical trial. First, a bit of housekeeping. Everyone except the presenters and the organizer will be muted during the webinar. This will help eliminate background noise and audio feedback interference. Questions can be sent by live chat. The chat can be opened by clicking on the chat vignette, that's the conversation bubble on your screen. We will aim to answer all of your questions after the presentation is finished. A reminder to people who are phoning in from a telephone line, please also sign in on your computer or tablet if you want to follow along with the visual presentation. If you cannot hear the speaker, see the slides, use the chat, or you get completely disconnected, don't panic. The presentation will be recorded and made public under Resources on our website. Our web address is qibd.com. That's spelled QUIBD.com. You'll also find other resources listed there and recordings of our past webinars. Don't forget to like us on Facebook, QIBD, and follow us on Twitter, @QCrohn'sTrial. And now to the reason you're all here. Today's presenters are naturopath Dr. Seema Kanwal, who practices in Vancouver, BC at Balance Medical Center, and Dr. Chris Boehner, founder of Paradigm Natural Care in Vernon, BC. Dr. Seema Kanwal is a graduate of Simon Fraser University, where she focused on chemistry and biochemistry. Upon graduation, she joined the Royal Canadian Mounted Police Forensics Laboratory in Ottawa as a forensic technologist. Dr. Kanwal then pursued her career in naturopathic medicine in Toronto, Ontario, and has been practicing in Vancouver since 2006. Since arriving in Vancouver, she's been an active member of the British Columbia Board of Naturopathic Doctors. She's one of the few naturopathic physicians to hold pharmaceutical prescription rights in British Columbia, and one of the only naturopathic physicians in Canada to be trained in the ApoE diet. Presently, Dr. Kanwal is working through the certification of integrative medicine through the Institute of Functional Medicine, IFM. Dr. Chris Boehner works with a wide range of patients who are looking for a balanced approach that combines conventional medicine with naturopathic approaches. Many of his patients are dealing with complicated health issues such as hormone imbalances, menopause and andropause, arthritis, long-standing joint injuries, cancer, and chronic illnesses such as Lyme disease and autoimmune diseases. In addition to standard naturopathic approaches, Dr. Boehner has advanced certifications so that he can use bioidentical hormone therapies, intravenous and injection therapies, chelation therapy, prolotherapy, and platelet-rich plasma injections for injured joints, and conventional prescription medications. Welcome, Dr. Kanwal and Dr. Boehner. To start things off, Dr. Seema Kanwal. Go ahead, Seema.
Hello, everybody. Thank you very much for having me on today. My name is Dr. Kanwal, and I have been in practice in Vancouver since 2006. There are a whole host of things that we see on a regular basis in my practice, but one of the main things that we're talking about today are anything that's gut-related. Oftentimes I have people will ask me if we can do any type of food testing or is there any type of stool testing that can be done? I mean, to answer that on a very short time right now is that there are so many different options out there for people, depending on which biologics they're on or if they're on any medications, or oftentimes I will end up seeing people who have tried absolutely everything under the sun, and now they're trying to find something that can potentially allow them to live somewhat of a more pain-free type of living. So one of the things often I get asked is, what are the foods that we're supposed to eat? What are the foods that we're not supposed to eat? So there's a very thorough history that I do with every single person to ensure, like, have they ever been on antibiotics? Are they currently on antibiotics? What is their history of that? And we know that, people that have either been exposed to antibiotics early on in their life have this propensity to potentially develop some type of inflammatory bowel condition later on. So, this is a very big topic, and we can, I'm sure, go into this discussion a little bit later this hour. And so foods is often another one that I'm asked about, of what foods are we supposed to eat, what foods am I not supposed to be eating. Again, that is really based on every single individual person. There's lots of different diets out there now, like ketogenic diet is very popular. Previously, there's been the zone diet and all these various different diets. And what I've always found is that everybody's a complete unique individual. So depending on the person who's in front of me, whether a low-inflammatory diet would be better for them, or is it a dairy-free, gluten-free diet, it is very individual. Not every single person, is able to follow the same diet regime, because everybody's needs and cultures it's all based on that in order to determine what will be the next step with that person. Thank you.
Thank you, Seema, for that great presentation. Now we'll turn it over to Dr. Chris Boehner for his presentation. Go ahead,
Hello,
Chris.
everybody. Great, thanks. Thank you. So thank you for everybody for taking some time out of their afternoon to sit in and listen on this. Hopefully we can provide you some useful answers and answer your questions and go from there. But I'd just like to start off here in saying that, one of the interesting things about what Q's doing is that it really is it aligns so well with naturopathic medicine. And, when we take a look at, the area that I've been working a lot in, which is this idea of inflammatory bowel, or what I'm referring to as gastrointestinal ecology, Q Biologics and the work that they're doing is really starting to make, some really impressive understanding, some research and some findings with regarding to this underlying pathology and what's happening. And at the end of the day, that's what naturopathic medicine is really all about, trying to find the underlying causes, look for the most appropriate way and the most unique way for the patient, identify their individual needs, and then help to sort of support the body in the process of healing. And when we take a look at what Crohn's disease and inflammatory bowel and what Dr. Kanwal was just referring to with regards to things like antibiotic use and diet, where I tend to put this whole sort of area and lump it under is I try to create these frameworks, and so that I can help explain to my patients what's going on. And this little diagram that I've got up on the slide on the presentation right now, this is really a circular process, and what we end up seeing is this sort of reinforcing circle of events, and it can start anywhere, but for many patients, what we start seeing is things like bacterial overgrowth or changes in the microbial flora. And then we see a buildup of different types of products from the bacterial growth. We see inflammatory processes. We see injury to the surface of the gut lining, impaired digestion of nutrients and then malabsorptions. And this cycle kind of goes around and around. And one of the challenges is that when we're dealing particularly with patients with inflammatory bowel disease is that this process is well established, and where is the best way to intervene? Where do we start to support a patient, and what's the best place that we can get the most effect from? So one of the things we start to take a look at is, this role of gut biology, gut ecology, what's happening as we start to put food into the gut, how it starts to affect the bacteria, and again, this is just another little diagram. I'm one of these flowchart mind map type guys, so this is how I tend to work through my own understanding of this, and hopefully you guys find that informative. But essentially, again, this is a similar type of thing, but a little more updated, and what, again, we start to see here is it's really this increased permeability in the gut that leads to these autoimmunity, this inflammatory process, and that starts to drive the symptoms, which then become self-perpetuating. When we start talking about things like leaky gut, leaky brain, leaky membranes, this type of thing, there's a saying in naturopathic medicine, which is when in doubt, treat the gut. And really I think what we're finding now, and again what Q has been finding in their research, is that this interplay between the bacteria in our gut, the mucosal membranes that separate the gut from our tissues, and then the immune reactivity that starts to happen is really, really key in all of this process. And this is a slide that Q actually has used in their presentations. And, this concept of this breakdown in the barrier, the development of this low-grade inflammatory process that doesn't necessarily resolve, is then generates this sort of unresolved infection and inflammation that generates the various symptoms. And this expands into things like Crohn's, inflammatory bowel, diverticulitis, irritable bowel. And with regards to things like the biologics, and tumor necrosis factor alpha inhibitor or antibodies, these are some of these inflammatory signals. And it's interesting because much of the work that I'm doing with patients is trying to sort of find ways that we can support them while they're on these drugs. And it can be a little bit on the challenging side, but if we go back to the basic principles of it, we can always support patients at the very basic level of repairing the gut lining, reestablishing the barriers, rebalancing the microflora, and then helping the immune system to sort of stabilize itself. So I'm really looking forward to how Q progresses. I'm very, very excited to be able to work with them, and look at how we can, use some of these naturopathic therapies to help, patients and see if there's improved benefits and things like that by adding in some of these basic concepts. So with that, I will turn it back over to the rest of the presenters, and we can move on from there.
Thank you so much, Chris. Now we're going to turn things over to Dr. Shirin Kalyan to moderate our panel discussion on integrative care and IBD. Dr. Shirin Kalyan is a translational immunologist and leads Q Biologics scientific innovation. She earned her doctorate in experimental medicine and is a faculty member in the Department of Medicine with the University of British Columbia. Dr. Kalyan has been studying the pathophysiology of disease rooted in immune dysfunction and metabolic disturbances for over 18 years. She was awarded the prestigious Humboldt Fellowship to conduct research in Germany to investigate how commonly used drugs affect the immune system in people, and also to harness the healing potential of the innate immune system for immunotherapy. Over to you, Shirin.
Thank you, Lai. And thank you, Chris and Seema, for your introduction to your integrative approaches. I've been really excited and looking forward to this particular discussion. I've spoken to you, both of you, at great length about holistic strategies for the treatment of chronic conditions, and I appreciate in particular the fact that you both bring scientific background to your integrative approaches to health and healing. This discussion was in part inspired, as Bonnie had mentioned, by the fact that people living with IBD are among the most likely to seek complementary and alternative therapies. This is taken, I think, as a reflection of the fact that the current treatment approaches to IBD are falling short of meeting the needs of most people living with this challenging condition. I was recently speaking to a professor from China who received his scientific training at Oxford, and he had heard about Q's treatment approach and wanted to know a bit more about the science behind what we're doing. And I was describing how Q's immunotherapy is directed at restoring the innate immune function and reestablishing the barrier function that is leaky and disrupted in most patients with IBD. And he kept mentioning, and he mentioned it a number of times, how closely this really aligns with the aim and focus of traditional Chinese medicine. This, of course, is in stark contrast to the current treatment paradigm aimed at suppressing inflammation and immune function. So my first question really is, how do you work with the current standard of care when you're treating patients with IBD? Is it challenging from an integrative approach to balance it with how patients are currently being treated? Either Chris or Seema, feel free.
Sure, I'll jump in. I can jump in here. Don't want to hog it, but it's always interesting. I mean, a lot of patients, when they come in to see naturopathic physicians, they automatically assume that there's a very counter-conventional medicine approach, and certainly within my practice, the way I kind of try and address this is say, look, there's a series of approaches and a series of steps that we like to take, and we want to start with the basic foundational work and work forward from there. And at some point in time, if you think of this as like a pyramid, the basic things like working on the diet and nutrition, working on, whether there's supplementation, nutrient repletion, repair, support of injured organs, this type of thing. Those are all things that can be done in conjunction while patients are also taking their conventional care. And so it's not an either-or thing, but it's a case of trying to understand, what is the patient looking for, and what are the specific symptoms that they're not actually finding resolved. And, and certainly as I've had this conversation with more and more gastroenterologists and internal medicine people, it's like, it takes away a lot of that friction, because now we start to understand where we're coming from and realizing that, it's not a combative, it's not a confrontational type thing. So, and I think patients really appreciate that, because then they can feel that they've got people that are on board as part of a healthcare team. And, hopefully as we go forward, we can start to continue to build those opportunities for dialogue, build on the understanding. And, every patient's a little bit different, and I think the reason that they're not getting the results that they want necessarily is because sometimes they're just not being heard. And if we can do that, help bring that into the care strategy, then I think that's really, really beneficial to everybody involved.
I actually agree there, Chris. I've had that same experience quite often. I mean, once we open up that dialogue with other physicians and other gastroenterologists that I've worked with over the years, once there's an understanding that there's that common respect that at the end of the day we just want the patient to get better, I have found that has really helped the patient actually feel a lot better, that they have people that have their back, and that and the compliance, it skyrockets on both ends.
Right, so that's an interesting thing that you're mentioning, that you're working with the physicians. Do you ever find pushback, or do you find them largely accepting that their patients are receiving complementary care?
There was pushback initially, I find, of course. I think with anything, when there's there's just the education is not there, or they're not sure where I'm coming from, that's the time that there has been pushback in the beginning. But as we've, opened the dialogue and had the conversations, it's a very cohesive type of communication environment for everybody then. There is initial, but then after that, I haven't found that to be the case anymore.
Oh, that's great.
Yeah, and I would say the same thing. I think the biggest challenge is that naturopathic doctors can be a very eclectic bunch, and we don't have specialties per se with what we're doing in terms of the medicine. So it's very hard to identify, what naturopathic physicians are doing and where their areas of expertise or experience may lie. So, if you go to a gastroenterologist, that you're going to be seeing someone who's going to see your gut, and that's not necessarily the case. So, again, it just, if you can open up that dialogue, if you can start to sort of say, hey, we're not going to take your patient off all the medications, here's some of the evidence that we're seeing, this is the rationale that we're going with, and there's that. And it does take time, there's no doubt. Not every doctor comes on board with, big hugs and, oh, I'm so glad you're here type thing. But if we do get those opportunities to sit down and engage in that conversation, I think there's more often than not a lot more similarities in the approach that we're taking. And the other thing I think is really important too, is that, medical doctors are super busy, and because of the way naturopathic medicine is practiced, we have an opportunity to spend a lot of time with patients. And I think that kind of gets, I don't think it gets utilized by the healthcare system in general, because we can actually sit down and very much be, help patients understand. And there's many patients that say, look, you actually need to go on some of your biologics right now because your disease is advancing so rapidly. And so, we can actually be a very useful member of that team and can really help, engage that patient by helping them understand and taking that time.
So do you find that patients come to you hoping to get off the biologics, or do they come to you for providing more of a supportive care with the intention of continuing on the therapies that they're currently on?
I actually get both. I have some patients that come in and say, I'm really sick and tired of this. I can't do this anymore. I want off. And I have patients come in this is what I've started and I want to stay on. I want to be stable. So really, I get both ends of the spectrum. I'm not sure about you.
Yeah, I get the same as well. Yeah, I mean, the patients that the biologics are working for, this is such a nasty, nasty condition that when they get any quality of life improvement, they're very, very hesitant to move away from something that can give them at least, can improve things. So often, that's part of it. Yeah.
have you noticed that there has been a change in terms of the perception, largely from the patient population, in terms of wanting to have an integrative approach? Do you find there are more people who are looking into this, or is it pretty steady state?
Oh,
I've had
it's
a
taking off.
skyrocketing of people.
Yeah, skyrocketing. Yeah. I think the big thing is that what's causing it?
Yeah, what do you think that is causing this change?
Well, I think, what I get mostly is first of all, there's just experience in the community. When people hear about somebody working, word kind of travels, and that's part of it. But I think the other thing is that there's some real disconnects with what is being communicated to the patient. And it just, because, we now have the internet, there's so much information that's out there. Patients are sorting through this and they're getting exposed to tons of different ideas. But when they go in and they talk with, their specialists, and their specialist says, diet has nothing to do with this, forget it, you're just wasting your time, that doesn't sit with them. And I think it creates a dynamic where the patient's going like, but wait a second, I have all these questions, and you're dismissing this offhand without any sort of a conversation. And that's just the way that healthcare is evolving now, that this is becoming, a conversation as opposed to those traditional roles as the doctor says, patient does.
Seema, do you have anything to add to that?
No, I would actually agree to that. That at this point, I have people coming in that say, I'm grateful that finally someone's able to sit down and have the time to actually listen to me, because I don't get that all the time. So there's been that dichotomy, I think, a lot with naturopathic physicians, that we have the ability to have the time, and so that when patients are sitting there asking questions, they're not feeling rushed to take off.
The number of new IBD treatments that are coming on board continuously, it's sort of a revolving door. Do you change your approach based on what type of treatment they're on, or do they even know or discuss their current treatment, and how do you work around that?
Yeah,
do you want to start with that? Yeah.
Sure. It's always very individual, based on what medications they're on, based on what symptoms they're having currently, if any, and based on what the patient's goals are. If the patient's goals are to maintain steady state, then that's what we work with. But it really depends on where they're coming in with, will determine, what the goals of the next, 3 to 6 months to a year, 18 months even look like. I'm not sure if that's answering the question there, but.
Yeah, well, and it's interesting too. Definitely different medications are easier to work with, and some are more difficult to work with. I think probably some of the most challenging ones are the corticosteroids, like the early use of prednisone and things like that. That the immunosuppressive element, but also just that the damage to the gut lining that happens with that. You kind of feel like you're swimming upstream when you're dealing with those ones. So when patients can finally get off of those, then we can start to work on some other elements of it, because that perpetuates that cycle of the leaky gut and that. So that's particularly difficult. The biologics, again, patients tend to go a couple of different ways. For most patients, the biggest problem is the intravenous infusion, and then they just have to, one may work for a while and then stop. Particularly with Remicade, I tend to see that one can work quite nicely to begin with. But then eventually we start to see there's a resistance to it, and then it's usually moved on to
resistance,
or something like
that.
That's
what I'm.
Yeah.
Exactly what I'm seeing now. Actually, in several patients.
Right.
Yeah, and especially with the stuff like when you piggyback on like Imuran or azathioprine and methotrexate, we are trying to actually rebuild that immune system a little bit, and so again you're kind of swimming against the stream a bit more as well too. But but generally what I find is that you can do a lot of really great stuff just by working with patients, trying to get them comfortable so that their digestive function's improving a little bit, they're not getting the urgency, and then you can start to just sort of begin to move forward from there. And you're going to have those different patient populations, which some are coming in, look, I don't want to go on, how do I prevent this? And then the other ones that do. And, again, each one of those is going to have a different approach as well.
Mm-hmm. Yeah, because I was thinking we're doing something completely different. We're actually trying to stimulate and restore immune function. And I would be assuming that the integrative approach is that you would provide a patient who is on, for example, our therapy would be very different from ones that are trying to suppress the immune function. Am I correct on that front?
Yeah. Well, I mean, there's a couple interesting things. Like it's interesting because when we take a look at some of the traditional naturopathic formulations that have been used for inflammatory bowel disease, there's one called Robert's formula, and it has things like some marshmallow root and echinacea and what was it? A couple. Oh, geez, I'm blanking on it right now. But there's a couple for stopping bleeding and things like that. But it's interesting because the echinacea always confused me a little bit. I'm like, what is that doing in there? And it turns out that when you take a look at what's echinacea do, it's actually one of these immune modifiers and immune modulators. There are various different sort of components of that plant, the constituents have that effect. And one of the things was, Shirin, when we were taking a look, I was looking at a couple other herbals after one of our conversations, and I found some really interesting stuff about astragalus, which is a Chinese herbal formulation that's traditionally used as immune. It's used in cough and colds and things like that. But, really interesting stuff that I found about it, showing about it repairing, lowering that zonulin level that happens with that gut degradation, and then doing the repairing to the gut lining. So you're absolutely right. I mean, if you've got someone that's being immune suppressed, those types of botanicals aren't going to work at all, right? Whereas if someone's coming in beforehand, then perhaps it could actually be quite useful.
Right. One of the things that we keep hearing about a lot, and is a major point of interest for patients, is this whole aspect of diet. Is there a perfect diet for a person with IBD, or is it really an individual?
Of course not.
Or have you found a success in one area or another? The big debates around diet. So who wants to take content?
Now ketogenic diet is like, this is the end-all be-all. You want to be in ketosis. I mean, that's great and hunky-dory, but then all of a sudden you see these kidney functions, and all of a sudden someone has to go on dialysis. It's like, wait a second, we got to back up a little here. So, of course, there's no perfect diet. It doesn't exist. It all is dependent on the individual person and what their symptoms are and what their sensitivities, if any, if there's an actual allergy situation or what have you. So it's just, I can tell you my own family, there's 3 of us siblings, and all 3 of us can tolerate different foods. Like, how does that work? We're from the same family.
Right.
Yeah.
Yeah.
Well, and diet. Oh, yeah. Well, yeah. How long do we have?
How long do you need?
Yeah. How long do you need? Yeah. Well, I think exactly. The diet, we like to think, well, this is the diet, this is the diet. And the reality of it is that everybody's different biochemically, the bacteria that live on and in us, the state of your gut, the medications that you're on, nutrient deficiencies, it goes round and around. And, where I start working on the gut part of it is, what's the most problematic condition that's happening here. So if you've got a patient, for example, that, they've got a lot of these symptoms that you can see that the gut bacteria is really messed off, gassy, bloaty, bad breath, all this type of thing, that's, anytime they eat certain foods, they just start to bloat up like crazy. That's usually like a dysbiosis issue, right? And that's one where suddenly like maybe something like a lower carbohydrate or carbohydrate restricted diet might be more important, But if you've got somebody whose gut is so compromised now with really advanced inflammatory bowel disease that their absorption issues are so compromised, well, you're not going to be able to have a patient that tolerates that either. So you've got to be really, really cognizant of, what's happening with that patient and tailor your treatment. And you have to, I'm always a big fan, and that's why I go back to my little diagrams, is if you can understand the underlying mechanisms of what are going on here, you can reverse engineer a treatment that addresses that, like I said, dysbiosis or inflammation or leaky guts, or various other elements of it as well too. And you say, okay, here's what's happening. What do I have in my quiver of therapies that I can use to build into that, whether that be dietary, herbal, nutritional, et cetera, et cetera, et cetera.
So what would a patient expect if they're coming to you for help? What kind of testing do you do to determine what is the best diet, what is the best treatment approach? How is the assessment made here?
Well, I'll jump in here. I usually start off with like diet diaries, believe it or not. Many patients, I'm always cognizant that, look, people are paying for this out of their own pocket. We've got to be careful about what we're using, and the key elements or the key deciding factor that I use when I'm deciding on a treatment plan is this testing going to change my treatment plan? And so, but I need to do my homework. I need to get the history so I fully understand the situation. Trying to use testing to answer questions that you haven't actually kind of thought about first and just firing a whole battery of, let's do this, let's do this, let's do this. That's just a fishing expedition. And again, patients, I think you got to be a little bit more, again, these tests can be expensive and some of them are really good and some of them aren't. But, starting from there, if I were to do other tests, I get many patients that want to know, food allergy testing. And I refer to it food sensitivity. I think you have to be very clear. And I think this is one of the things that really compromises the relationship between medical doctors and naturopathic physicians is that when we start using inaccurate language, and the tests that we use or that I use for food allergies or food sensitivities is what I refer to them, has got more to do with looking at the antibody levels in response to certain foods and what's there. So we're looking at, is there an immunological response to certain foods? And you can learn a lot from that, like whether the gut's leaky and are there certain things that may be driving that. And then one of the other tests that I'm starting to look at right now is this microbiome, and sort of the gut permeability issues as well too. And it's complicated. I mean, there's a lot of interesting stuff that's going on with it, complete digestive stool analysis, short chain fatty acids, calprotectin, inflammatory markers, immunoglobulin type A, those types of things start to give you a much more, an interesting sense of what's going on and also give you some really practical ideas on where to intervene. But like I said, normally with a diet, I mean, I've run thousands and thousands of food allergy panels. I can usually tell most of the time by looking at the diet what the problem's going to be. So,
right.
I'm very similar as well because these tests are a lot of money. So I'm very mindful and cognizant of how much these things cost, and sometimes they're not always the answer. So often I'll start with just some simple basic labs, like even a simple thing like a CBC and just an iron level to make sure that that's not, part of the problem. It's just that the energy storage is just not there in somebody. So really when it comes to extended testing is really based on what their goals are again. And some patients really, really want to know what my food sensitivities are, and that's what they're coming in for. But other people, again, we do something simple like just give me like the last, 3 to 5 days of the things that you've eaten on a regular basis, and then we can tweak something just from that alone, and they start feeling better. Then we didn't have to spend hundreds of dollars on a test to know that this food is not something that is potentially beneficial for that person. Mm-hmm. And then based on that, we go further if needed.
You had mentioned previously about the use of antibiotics and its contribution to various GI problems. Did you want to expand on that? You were getting into some of the meat of the issue right there, and how do you deal with it's quite a widespread, and sometimes you often don't have. If you have a gut infection, that's probably what you'll need to be treated with to deal with it. Yeah,
absolutely. I mean, there's some gut bacteria out there that we can do as many herbals as we want, but if that bacteria is not responding, then we have to unfortunately bring out the antibiotics. And when that is needed, then you do that for the course of those 14 days or 7 days, whatever the case is. And then hopefully that then you end up having to deal with the ramifications afterwards, which is still beneficial for the person, because if they've got, let's say it's like Blastocystis hominis, that sometimes you cannot deal with just straight herbs. You have to get in the Septra, you have to get in some type of antibiotic to be able to deal with that type of bug. And until you actually get rid of it, the patient is not going to be feeling better. So antibiotics, I'm not against them, nor am I for them. I'm for, if we need them, absolutely, let's use them. And if we can, let's say somehow not take them, well then we can avoid it. Like SIBO is another one that's a good example. I have patients that do amazingly well on the herbs, but at the same time, I still have patients that don't respond to the herbs that still will then end up needing the rifaximin, the antibiotic that's typically used for SIBO. So it's really a patient-by-patient basis, depending on what the person in front of me actually needs in that moment, would determine if antibiotics is something that is going to be really beneficial for them, or if that's something that, we're skipping too far ahead too quickly.
Right.
Yeah.
Yeah, go ahead, Chris.
Well, I'm just going to say that's a great answer about, that's the graded response. It's like, well, let's use the least invasive, the least toxic, and, first do no harm, and then move forward, with things that require more, bigger guns, if you will.
Mm-hmm.
Right. Do you find that there's an age sensitivity to antibiotics in terms of reversing some of the dysbiosis that might occur subsequent to use? Like, are we more resilient after a certain age, or are we sensitive, or is it really dependent on the individual themselves, really?
I would
it's
say
really dependent on the individual.
Yeah.
For me personally, that's what I've seen in practice. I mean, I have 20-year-olds that don't even respond to either, and I have 40-year-olds or 50, 60, whatever the case is, where herbs do an amazing job. That they'd actually do the opposite. They don't respond at all to the antibiotics. So
it's funny.
I've seen it all over the map.
Yeah, I live up in the Okanagan here, so I get lots of farmers and things like that. And I have to admit, some of my patients who are in their 70s and 80s, and still out there working away like crazy, they're the most vigorous people ever. I mean, it's astounding.
Yeah.
And then it's like great. And then and I think speaking of the antibiotics, is this. I mean, there's a change. If you take a look at a kid who's had ear infections and multiple courses of antibiotics, and then treatment for acne and tetracyclines, and and then goes on and on. You get that microflora being disrupted from an early age. And when you take a look at stuff like like the Swansea trial, for example, that shows that early development of the microbiome, through the birthing process and through breastfeeding. I mean, that has a huge implication on immunological development. And, and I think the concern is that the younger that kids get put on long-term courses of antibiotics, that's difficult to repair, because that whole gut ecology changes. Like that microbiome dictates so much, all the way down from, mucosal barrier function, immunological tolerance, neurological function, digestive function. And sometimes that's, it was like they're compromised right from the very beginning. And it is interesting, I think, that you're starting to see more and more. I mean, that probiotics now are everywhere, right? And it's like, take a probiotic. I had a patient come in today from their oncologist, and their oncologist said, go see the naturopath and you should do a probiotic. And, and you're like, wow, okay, that must be getting some traction. We're actually getting discussions at that level about it as well, too. So, but yeah, you've got to be judicious, and that's the thing is this type of condition, healthcare, it takes time, and we can't, protocols for the average person. There's no such thing as an average person, right? So you're going to miss a lot of patients with that. Yeah.
I always say 9 out of 10 stats are wrong. So how do we explain that?
It's very true, Seema. Yeah. So when we're talking about changing understanding and treatment approaches and a broadening of ways that we deal with chronic illness, one of the things that is changing quite rapidly, and I think, Chris, you probably are most familiar with this, is the use of medical cannabis for the treatment of pain and in a lot of chronic conditions. Have you guys had any experience dealing or recommending or treating patients with IBD with medical cannabis?
So not to get into trouble here, because we have to clarify.
Exactly.
I didn't want to get you into trouble, so do clarify anything you need to.
Yeah, so yeah.
Technically, we're not allowed to endorse it. We're not allowed to, describe it. It's not in our scope of practice, sadly.
Yeah, well, technically, the way the rule works. Yeah, well, so I'm on the regulatory college, and so I'm very familiar with this. I mean, the challenge of it is that you've got a couple different things. The law as it stands right now says that cannabis is illegal, right? And so the problem becomes is that if our naturopathic physicians start facilitating access to cannabis for patients, the problem because is that you're doing something that's illegal, and that's not what the regulatory body can permit. We can't tolerate that. Yet at the same time, we're caught in a situation where this stuff is everywhere. It's so prevalent. And so, and the argument that I have made with within the college has been that, patients are using this. We are going to have a conversation with it. If we have a patient that comes in and says, I've got problems with substance abuse, are you not going to have that conversation with them? And certainly there's got to be an element of some harm reduction as well too, right? I mean, if patients are coming in and talking about certain things that they're using and you're like, what the heck, and there's some scary stuff that's out there. And like I said, I live up in the Okanagan, which is like cannabis central. I mean, you can't swing a stick without hitting a grow up around here.
And Vancouver's not any better, Chris.
Yeah, exactly.
So something here.
So here's what I'll tell you is that, I do have patients that come in that have accessed cannabis either through their medical doctors, they've received authorizations through the LPs, or they've had the MMAR authorization, so they have their supplies, and their doctor has basically said, I don't know what to do with this. You should go talk with a naturopath. And you guys, thanks for throwing us under the bus, guys. That's really helpful. So we do, so I have engaged in the conversation with patients on that, and when they've got their legal sources and worked with their medical professionals on them with this. I was just over in Amsterdam, the interest in cannabis at the International Cannabinoid Research Society. We're seeing really, really remarkable things that are showing with gut healing and, microbiome. I was just talking with Dr. Ethan Russo. Ethan Russo's, he brought Sativex to market through GW Pharmaceuticals, so he's probably one of the most highly respected people within the medical cannabis field. And I had the opportunity to have breakfast with him a number of days in a row, and all we chit-chatted about was microbiome and cannabinoids, and there's a huge level of interest that's going on there. And clinically, I can say that I definitely see patients, do derive benefit from it. And I think the confusion of it is one, we don't know necessarily what patients are getting all the time. Right. So I think as we move into this new framework with licensed products that actually we know what's actually in them, that are standardized, I think that's going to make a huge difference for patients. And I think we'll see that reflected in the scientific investigations and literature as well. So,
yeah, because
I could go on.
Yeah. Well, we may have time to go on. It is something we've noticed. There are patients that come into our trial who are on various types of marijuana or cannabis types formulations to deal with various issues related to their condition. So I was assuming this must be something you encounter quite a bit. I don't want to hog both of you for the entire hour. I want to give other people who are on the line an opportunity to pick your brains. And I really recommend that if you have something you would like to ask either Seema or Chris or both about, please do so now. Send it through the chat. And in the interim, I will just give everyone listening an overview of the trial that we're currently running that I mentioned. Biologics is currently doing a phase 2 trial. Our aim is to evaluate the effect of our therapy on endoscopic healing and remission. We'll be looking at clinical remission and the safety and tolerability of our treatment. We are using QB Echo SSI, which is actually an immune stimulant as opposed to an immunosuppressant. So we're coming at this at a completely different approach, as was mentioned. Initially, this is a 2-stage trial. The first stage is an open label study. And so that means everyone who enrolls, the first 20 patients, everyone will be on the drug. And that's because the first 20 patients' aim is really to look at when is the best time to look for mucosal healing. Is it week 16 or week 26? And we'll be running the trial across 3 sites in Canada. There's one in the Fraser Valley. We have one in Vancouver and in Ontario in Hamilton. We will provide the transportation to the clinical site if you are eligible. If you want to know whether or not you're eligible, I'll put up the pre-screening questionnaire website soon, shortly after. We can move to that. And you'll be put through to a recruitment nurse, Andrea Cameron, who will make sure that you fit generally the criteria that we're looking at, and she will refer you to a particular site if you're eligible to apply. Thank you for listening, and we will now move forward with the questions we have. What are the questions?
So the first question is regarding a patient that when her daughter was actually a pediatric GI clinic, there was full pushback with regard to the integrative medicine approach.
Mm-hmm.
Now that she's older and she needs to take the biologics for the first time in 11 years, she wants to continue with the integrative approach. Any advice as to what she can do to continue to benefit from integrative medicine?
Who wants to tackle that one?
Well, I think, one of the things that I've seen with patients on the biologics and the things that we try and work with from an integrative standpoint, and I guess there's a couple different things. Communicating with doctors is one thing, and that if you're working with somebody who's helping you in that integrative care, trying to find, asking them if they can communicate and create some sort of relationship with your other members of your healthcare team would be important. And I think it's important not to put the patient in the middle and have them act as an intermediary between both teams. And I think that, as professionals, it's incumbent on us to put the patient's interest first and to really try and engage the other parts of that. So that's the one thing. With the biologics, I think, like I said, you see that's, the reduction in the tumor necrosis factor alpha, Remicade, Humira, this type of thing. And, I think that's a useful strategy because it starts to, bring down the cytokines that are driving that damage to the mucosal lining. So I think that's, that's obviously what their intended effect is supposed to be. One of the things that I find that on an integrative standpoint that you can really start to take a look at is try and, look at those underlying infections, seeing if there's ways that you can help to sort of modify that gut bacteria and then also heal the gut lining. And those are the things that I start to work with on those patients. So I use a lot of things like the oregano oils, we'll use curcumins, Oregon grapefruit, some of these natural antimicrobial compounds that can help modify gut flora and make sure those are on board. And then, like I said, the gut healing part of it, settling things down with things like curcumin and boswellia, which have these natural anti-inflammatory effects that can help, and then supporting gut healing with things like astragalus or glutamine or, marshmallow root, althea, those types of things. So there can be a very graded approach, and you can definitely continue with that integrative care while you're on those biologics. And I think, sometimes these biologics don't necessarily work forever. And I think if you can just really, create an opportunity for as much healing and take advantage of the quieting down of the inflammatory storm, if you will, and work as quickly and as hard as you can on that, then you can get some really long-lasting effects.
Okay.
Next question is, how do you decide which types of probiotics are most appropriate, multi-strain versus individual strain?
Seema, do you want to talk about FOS?
Sure. Every probiotic is so different, and not everybody actually needs any probiotics. There's this whole big push about, everybody needs a probiotic, and everyone's drinking kombucha, and everybody's having all these fermented things, and it's a little too much for some people. And so really, it's individual based on whether somebody would actually benefit from a soil base versus a sugar at the end of the day is particularly going to affect some people, and some people I have found that have been on the biologics have had a greater reaction to probiotics that actually contain something called FOS, which is fructooligosaccharides, and that's a sugar that's feeding the bacteria. So, to answer that's really individual. It really is dependent on what the individual person's microbiome is like, what is their functioning like, do they have any type of small intestine bacterial that's overgrowing, or is there an issue in the large intestine? Like, this is such a loaded question. I don't even know where to go with this, but Chris, if you have something to add to it, because it's just it's one of those, supplements that's definitely not for everybody. When people are on it, when they come in, I actually ask them to come off right away and give their gut actually a bit of breathing space first.
Yeah, exactly. And I very often discourage them from doing a probiotic right off the bat until we've got a better sense of what's going on. I think, there's some interesting stuff like some of the plantarum, Lactobacillus plantarum, Lactobacillus casei, salivarius, that have shown some interesting effects on the cytokines, So could there be something there, and could that start to shift that? And again, I know the soil probiotics. There's all sorts of these different ones out there. I tend to say human level, the human microflora is where I tend to go. I keep them away from fructooligosaccharides as much as possible. We start with very small dosages, but really, I do that after we've actually sort of said, okay, look, there's some gut healing that's taking place here. We finally got a home for your bacteria to live in, because this is the big thing, right, is that inflammatory bowel disease is about a breaking down of barriers. You've lost that separation between the intestinal lumen and then the tissue. And until you've actually repaired that, then all you're doing is funneling it in. And this is why you see so much confusion around, is there an infection in Crohn's disease? I mean, is there something? And then they're like, well, it looks like an infection, and we see this in animal models, and there's an infection, but there's nothing pathogenic. Well, it's because it's not pathogenic. This is part of your normal flora that's been displaced. And so throwing more microflora at it that can get displaced just doesn't seem to make a lot of sense in my mind.
Right. That's a very good point. Are there any more questions coming in? There was one that was submitted regarding the role of synthetic variants of cannabis. Is that a better approach or treatment?
No.
Okay.
No.
That was pretty clear, Chris.
Yeah. No. I mean, seriously. I mean,
completely second that. Absolutely not.
Yeah.
No
absolutely
synthetic
not.
cannabis. Okay.
No. No. I mean, the problem with it is this is the funny thing, right? Is the more we learn about it, like this is truly the epitome of naturopathic medicine. Is that the sum of the parts is it's just so much greater than the whole. I mean, it's every time they've tried to make a synthetic cannabinoid, it's gone horribly off the rails. I mean, we've seen cases where, like some of the like the FA inhibitors, which is the fatty acid amide hydrolase inhibitors. There was one in France that was done by we'll just keep that out. And a company that shall remain nameless. But it went terribly wrong, and we saw people with massive psychoses and death and things like that. So, I just say that the synthetic stuff, it just doesn't work. And when patients do use some of these things, like the nabalones and that, they find that a lot of adverse effects come with it. So there's a lot of modulating components within cannabis. There's these various terpene compounds, the other cannabinoids, cannabigeraniol, cannabichromine, these types of things, the acidic forms versus the decarboxylated forms, those all have different impacts, and they moderate the effects of it. So whole plant medicine with cannabis is definitely, that seems to make the difference for many, many patients.
So one of the questions, and I don't know if you have an opinion on this or not, is do you know which biologic, if any, is the lesser evil? For example, Humira versus Stelara.
I don't have a lot of experience with Stelara. I mean, most of my patients that come in here are either Remicade to start off with or Humira.
Yeah, me too.
I've had a few. I've started to see the Stelara in that. Yeah, I mean, I always make a joke with it. The Remicade, that's a mouse antibody. So I tell them if they start craving cheese or something like that, maybe there's a problem with it. But it's just a bad joke. But what I generally find is that Remicade patients, you end up failing off on, and especially with those patients that have the really aggressive fistulizing disease, they seem to respond well to it, then kind of fall off of it for some reason after a while. And I think that's probably the most difficult disease of them all, actually, is the fistulizing stuff. And again, it's the immunosuppression. You've got this bacteria that's burrowing away, and then how does the immune system fight it? And that only perpetuates a larger inflammatory response that drives that whole tissue destruction on top of it. So if there's one case that I say that's the biggest problem, but I can't answer which one's better. I tend to see, if I were to offer a preference, it would be Humira.
Right.
Okay. And maybe one final question, because I know our time's coming up, and maybe this one I'll give to Shirin. I'd like to know more about the Q Biologics product for Crohn's.
So the product that we're currently testing is called QB Echo SSI. SSI stands for Site-Specific Immunomodulator. it was derived from an inactivated gut pathogen. So what we're doing is actually stimulating new immune cells that are able and competent to come to the gut area to clear the dysbiosis and rebuild that gut barrier function. So we're not trying to block the immune system. We want the immune system to do its job better. So the understanding of Crohn's disease now is really that it's not an autoimmune disorder. It's really a lack of immune resiliency. If you look at the genetics, the background of people with Crohn's disease is really that they can't respond to bacterial stimulation optimally. So this really goes back to the hygiene hypothesis, the idea of that we haven't stimulated or trained our immune system to a very good extent, which allows the barrier function. Your gut is the area in your body that is exposed to the most abundant ecology of microbes anywhere. So you really need a good, it's called the microbial distance between those bacteria and yourself, the host. And so what we're trying to do is rebuild that barrier function by optimizing the immune response, that there's this host microbe interaction that's pivotal for making sure that the relationship between our microbiome, all the bacteria that we live in, and most of them when we're healthy are really helping our optimal functioning. We're learning more and more about how the microbiome really influences our health. So what we want to do is make sure that that barrier function is intact. If the barrier function is intact and your immune system can hold its barrier well, then you won't have this chronic inflammation, which is really a response to the invasion of your epithelial cells. And when your normal bacteria invade that space, this is what causes the collateral damage and that chronic inflammation and the damage that ensues. And it's hard to reverse from that without really getting a new army up there and making sure that that barrier is rebuilt. So we're testing this novel approach. It's a completely different way of approaching the disease, that can we go upstream of the symptom management, which is what current treatments are doing. We're currently trying to subdue the symptoms of the disease and go upstream to where the cause of the disorder really stems from. And so that, in a nutshell, is the therapy that Q is developing for Crohn's disease. Yes.
Okay, thank you so much for taking the time to join us. We're out of time, and thank you for joining us for Q Biologics webinar about alternative medicine strategies for treating IBD and how those can be integrated with more standard or conventional approaches. We really appreciate your great questions. A special thank you to our experts, Seema and Chris, for joining us today, and thank you to our moderator, Shirin, for leading such an engaging discussion. You can always find more information by going to our website, qibd.com. That's QUIBD.com. That's where a link to a recording of this webinar will be posted next week. If you'd like to sign up to participate in our current clinical trial of QBECHO for Crohn's disease, your first step should be to complete our online pre-screening questionnaire at www.restoretrial.ca. After that, our clinical trial recruitment nurse, Andrea Cameron, will be able to start guiding you through the clinical trial process, and if you're a likely candidate, refer you to a trial site. Remember to follow us on social media. Like us on Facebook, QIBD, follow us on Twitter, @QCrohn'sTrial. Thanks for joining us, and stay tuned for upcoming news and events. If you're in Southern Ontario, join Dr. Kalyan for an in-person talk at Oakville on Thursday, August 23rd, in partnership with the Canadian Digestive Health Foundation. You'll see the details of address and time on the screen. Go to www.cdhf.ca and click on Q Biologics Public Forum to register. Thanks again for joining us.
Bye.
Bye-bye.
Bye.
Bye-bye.